Yeah, so was it a mandibular fracture, Sona?
Yes, yes.
This side?
So, yes.
So she could not, the time was spared because she could not have to do.
No. It wasn't it didn't come to us. It
Okay.
came to cardiology because of this.
But this case can be managed
result.
with, if it not have been a mandibular fracture, this case could have been managed with the mandibular swing procedure as well. This was
Listen,
we wanted
so
to.
he had a mandibular
There was a
fracture, but he
malunion.
went to there was a malunion, but he went to cardiology because of his aneurysm. Then he came. Then they told, "Okay, bhai, do whatever."
Okay.
That way.
So you did the.
No, so he'll tell you what. We've not done anything for the trauma so far.
Okay, you will do the marginal.
Area where mandible was already fractured and malunited, so we lifted the similar way sir showed, lip slit incision, and we lifted the mandible laterally.
Right.
And whatever aneurysm sac was there, so that was excised. Then the mandible was put there. Maxilla and rest of the condyle was also not there, so that we have not done anything so far. So the idea why I think ma'am was stressing the importance of having a maxillofacial surgeon in the team, right? So even if you're not trained with oncology, because this case was refused almost all over in civil. Somehow they caught, Department of GDC maxillofacial surgery, and we were into picture. Otherwise, such kind of cases might be happening everywhere in India, everywhere. So this is how.
That is another thing that I want to add. Please, no matter how senior you become, please do not let ego even enter inside your room. It's an absolute no. Okay, I am the HOD and I'm very senior and all, but had I said कि नहीं ठीक है, this is नहीं वो नहीं होगा and I don't do it or whatever, what would have happened to the patient, right? So I call Gunjan, I call Vipul. Vipul is my own PG student. I get stuck sometimes because I don't do cancer and he's been trained in oncology. So I call him कि भैया मेरा ये कुछ हो रहा है तू कर. So that is the main thing about surgery and beyond. Please do not let ego get into your brains. It just doesn't work. It stops your progress as an individual and it stops the good that you can do for patients. Please always remember this.
Rahul wants to add something.
Yeah, pseudoaneurysm is I have seen 3, and among my very few publications, there are 2 editors. I'm not very proud of the number of my publications. One of them is in our journal. It's on pseudoaneurysm of the internal maxillary artery. It's very important to recognize pseudoaneurysms will always be seen mostly in our situations post-condylar trauma, post very bad condylar trauma, and they'll pop up. I don't know about this history. Generally after 6 to 8 weeks. So there is no swelling immediately, and after so I have seen one superficial thyroid, superficial temporal, which is very easy. Just get 2 controls and put your finger, it'll come out. One internal maxillary artery, which was embolized, and then put your finger and get it out. The third one, we didn't have a DSA facility. This was around 15 years plus back in Baroda. It was reported as superficial temporal. So I thought, okay, I've treated 2 superficial temporal. So I took the patient up and exposed the superficial temporal and put my finger. Profuse hemorrhage was there. I had to pack it. I took the control of the carotid, put the vascular loop over there. The mandible this was referred by a plastic surgeon. So the mandible he fixed was in the midline, the mandible was like this. So I had access to the internal maxillary artery. A pseudoaneurysm is not a total, there's a rent. So then I could identify the rent. I sutured with 5-O-proline and reduced the mandible. But it's an interesting article. You can, Rahul Thakur, Journal of Maxillofacial and Oral Surgery. You can read about pseudoaneurysm. It is a rare thing, very important. If you don't recognize it and if you go in, you will be in real trouble.
So one thing yesterday we were discussing, me and Siddharth, when you have to take a control over the external carotid. So how will you identify that the control is there? How do you identify? Anybody? Raise your hand. How will you identify that the external carotid has been tied out?
Clinically, how do you understand?
Clinically. Anybody?
Clinically, how do you understand that the external carotid has been? You have
Raise your hand.
Or you have controlled the external.
What are the 2 terminal branches of external carotid? Superficial temporal and internal maxillary. Okay, and then if you on the temple there the pulsations will not be there.
On the temple, I just see there is no pulsation in the superficial temple. That's
Only thing is the BP is less than 80, you will not get a superficial temporal pulsation.
Half minute, I want to take half minutes. One case already reported, ma'am, just pseudo, I want to share my experience. One case from AMP New Delhi when I was a SR, we managed, how we managed, just I want to share this story among you. One case, bilateral pseudo, after bilateral condyle fracture and parenchymal symphysis fractures, patient was managed previously by the Safdarshan hospital just by putting the IMF. After a 10 or 20 days, patient get a huge swelling and it was expected that it's an infection. Patient came to the AIMS in our department and we then we take history and normal NCCT. That's nothing is only just we found that it's not a even clinically little bit pulsatile we have feel. Then we talk with the interventional radiology. Go for embolisis. If you have a facility of DSA embolisis, are already mentioned. That's a very good thing. Very good thing. So first we take this patient. I personally talk with the radiology, interventional radiology department and took patient there and we get embolized both the sides. So that the opposite side will not go bigger and the whatever is there, it stops internal maxillary embolization. After waiting for 2 or 3 weeks, we again go by submandibular and it's not, we are not worried because we are already discussed with the interventional radiologist. Now you can go and you can take out whatever the hematoma is there. Everything we hematoma we go, but meanwhile we also care because 2-3 week hematoma might be the some abrasion and rent in the external carotid artery. So we have to very risk about that. But meanwhile we also keep by hand either embolization, either ENT people, or either we can do the external carotid ligation. So we keep this all things ready and we operate. But by God grace, nothing will happen.
If you embolize, if you want to operate, if you embolize, you have to operate within 2 days.
No, but
24 to 48 hours. But if you don't want to operate, but you just want to embolize, but the diagnosis has to be is very important. Carotid angiogram. So if you want to embolize and the tumor is not accessible and just if you want to address the tumor by embolization, so aneurysm will not come out or dissolve on its own. So we are here talking about the access. We are not talking about the JNA, nasopharyngeal angiofibroma. After embolization, it will dissolve. It will become like a rubber, okay, and it will come out because but aneurysm has to be dealt surgically if it has to be dealt. Otherwise, you can do only embolization, but it will not resolve.
But it
on
will not
embolization.
resolve after 2-3 because hematoma is get. It will
Yes,
resolve
yes.
after 6 months.
Yeah.
So we remove it.
So let's just assume that our discussion is over. Okay, so now you will finish the.
Bilateral is the only case, the rarest case. That's why it's published in the
Very
Russian journal. You can read.
Great.